much more. So let me just share my screen so that we can see what we are talking about. Just a minute. Okay. Can everyone see the screen?
Yes,
yes, please, we can say thank you, Sarah.
Okay, thank you. So as I was introduced, my name is Martha Mushi. I'm working with the Catholic University of Health and Allied Science in microbiology department as an associate professor of mycology. And I'm honored today to talk about neglected fungal diseases and some diagnostic challenges and even management challenges that we're facing, especially in Africa, in our continent in Africa. So to start with, I'll just have a simple introduction on what is fungal diseases when someone is talking of fungal diseases. So these are infections which are caused by pathogenic fungal. We can remember that fungus, they play part in our body as normal skin flora, as a normal flora in the mucosal lining. But at time when the pH is changing, when the environment is changing, then they can change as well and they become pathogenic. They produce different virulence factors which lead them to become pathogenic. And they cause us a wide range of infection, away from superficial or cutaneous infection. The common infection that we know, like tinea pedis or athletic foot, tinea corporis, which are on the skin, or the tinea tapetis, which are happening in the head, very common in children. But it goes to wide range. We have subcutaneous infection, we have mucocutaneous infection like vaginal candidiasis, we have oral candidiasis, very common in immunocompromised individual, but it can also go far to invasive fungal infection, and this is the life-threatening infection when it goes to the invasive fungal infection, like blood fungal infection. This include blood candidiasis, include blood cryptococcosis, include blood aspergillosis. So all these invasive fungal infection, these ones are the life-threatening infection. And these are the ones we are worrying, we are worried more than the localized infection, like the cutaneous infection. And the fungal is one of the neglected diseases, neglected tropical diseases, simply because it does not get that much attention as you compare to other infectious diseases. When you talk of antimicrobial resistance, someone think of antibacterial resistance. No one will think about antifungal resistance. So you can clearly see that the neglection starts from there. And this neglection starts from the diagnosis. It underdiagnosed. Fungal infections are really underdiagnosed, especially in Africa, Sub-Saharan Africa in particular, and underreported. And since they're underreported, the clinicians are not aware of the fungal infection as much as they're supposed to be aware of them. And this has led to the low suspicious index of fungal infection. Whenever the clinicians are managing patient, thinking of fungal infection, it's way back on their mind. They don't think of it at state as the way they think of the bacterial infection. So all this has led to the underreporting and underdiagnosis of the fungal infection, because if the clinician does not request for fungal infection, then as in the lab, we cannot go ahead and do fungal diagnostic test. So this has led to silent epidemic, because most of the times when these fungal infections are recognized or are being detected, it is at late stage, and this has led to a very high mortality, especially in Sub-Saharan Africa. We should remember Sub-Saharan Africa is hosting a lot of immunocompromised individuals, include HIV infected individuals. About 75% of the HIV population is living in Sub-Saharan Africa. So you can see that we are having a lot of immunocompromised individuals, but we are having cancer patients as well. The number of cancer cases are reported from Sub-Saharan Africa, of which these patients are also at risk of getting fungal infection. And these are at risk of getting invasive fungal infection, the life-threatening fungal infection, the one that we are worried about. So talking of the burden of fungal infection in Africa, it's very wide, and started from the localized cutaneous fungal infection like Tinea capitis in African children is reported to be about around 23%. But going up to the invasive fungal infection, something like cryptococcal meningitis, it's reported to be very high, and it goes up to 73% of HIV-infected individuals who are presenting with the signs and symptoms of meningitis. So they are diagnosed to have cryptococcal meningitis. But it's the same for pneumocystic kidney pneumonia, the PCP pneumonia, which has very high mortality the moment it's missed out, especially for HIV-infected individuals who are not using prophylaxis, the cotrimoxazole prophylaxis. So these are the ones which are at high risk of getting the PCP. But nowadays we have the fungal asthma, which have increased. When you look at the epidemiology, the cases of fungal asthma has highly increased, and this is due to the increase of atopic individual. Even in African continent, we have a lot of people who are atopic, and they are using a lot of corticosteroids for the asthmatic condition, and hence keep them at risk of getting fungal infection, and include the fungal spores, which lead to the fungal asthma, which is also present in Africa. But when you go to the common infection like vulvovaginal candidiasis, the study that we did back in 2022, we found this was a systematic review of the vulvovaginal candidiasis among women in sub-Saharan Africa. So the pooled prevalence was up to 33%, which is very high. But looking at oral candidiasis and oropharyngeal candidiasis, the pooled prevalence is reported at 48%. And when you look at blood candidiasis, which is life-threatening, but the prevalence is ranging from 29% to 76%, and this is based on the population that has been studied and the population of the individual that have been involved in the study. But we should remember, we should not neglect the oropharyngeal candidiasis, because oropharyngeal candidiasis is one of the predisposing factors to get blood candidiasis. So if these patients, these 48% are not managed on time, correctly managed on time, they are at high risk of getting blood candidiasis, and blood candidiasis mortality is very, very high. And on top of these blood candidiasis and other fungal infection, Africa, we also have the neglected and the emerging fungal infection, which have also been reported widely, and these include subcutaneous candidiasis like mycetoma, which has been reported in mycetoma barrier from Mauritania. If you look at this map here, all the way from Mauritania to Sudan to Djibouti, we found there are a number of cases. Sorry? Baluk?
You can carry on. Let me see how I can manage.
Baluk, could you mute? Baluk?
I'm struggling to mute.
Sorry for that interaction. We can proceed. So on top of the common fungal infection like cryptococcosis, like vaginal candidiasis, oral candidiasis, Africa, we also have the emerging and neglected fungal infection like mycetoma, which has been reported from Mauritania all the way in the mycetoma belt up to Ethiopia here, up to Kenya, our neighbor there in Kenya. They also have reported some cases of mycetoma, but not only mycetoma, we see the blastomycosis, which is also subcutaneous candidiasis. The blastomycosis has also been reported in a number of countries, include Uganda, include DRC, the Democratic Republic of Congo, and include Tanzania. So these subcutaneous mycosis or neglected mycosis, they're also a problem in Africa. And yet we still have low suspicions index from clinicians and the low diagnostic capacity, which lead to the low reporting of these cases. But looking at the imaging, another imaging fungal pathogen like Candida auris, which has gained popularity in the globe because it has gained a public health attention because of its resistant pattern to antifungal. Candida auris is one of the yeast pathogen which is resistant to almost all the antifungals that are around, and managing it is very critical, and most of the time it causes a lot of mortality. And it has also been reported in Africa. We have some number of publications from South Africa, but we have a publication from Kenya where they've also reported Candida auris. And recently in Tanzania, we have one study that we are conducting in our teaching hospital, Bugando Medical Center, and we have noticed the presence of Candida auris among hospitalized individuals. Some of them are colonized by Candida auris. These are studies that we have not yet published, but it's ongoing study, and we have noted the presence of Candida auris. But on top of Candida auris, we also have Candida lucida, which is closely related to Candida auris, and it has highly been reported from Africa. So even when we have neglected or low number of Candida auris cases that have been reported, we have the Candida lucida, which also has high resistant pattern similar to Candida auris, and it's a lot in Africa, of which it's also a problem, and it's also a problem when it comes to its management. And someone will ask himself, what are the drivers? Why is Candida infection more common in Africa? Because we should remember that we are in tropical region, Uganda, Kenya, Rwanda, Burundi, we are in tropical region. So being in tropical regions, we have an environment which favor the sporulations of the fungal spores, and also germinations of these fungal spores, and leading to the fungal infection. The humidity, the temperature, and the environment that we are living, it has high favorage to fungal pathogens. But on top of that, being in Africa, having 75% of population which are HIV infected, we are hosting patients who are at high risk of getting fungal infection, and this includes a number of fungal infection. When you look at HIV infected individual, the HIV predispose them to getting a lot of fungal infection, including histoplasmosis, pneumocystic, including cryptococcosis. All these ones predispose them to get infection. But we should also, on top of that, we should also remember that Africa is among the underdeveloped countries, among the countries which are still developing, and poverty is one of the big driver for HIV, is one of the big driver for tuberculosis, and all these are the predisposing factor to fungal infection. So as long as poverty is in Africa, as long as tuberculosis is in Africa, as long as HIV is in Africa, then fungal infections are there in Africa. The only problem that we are having is that they are underdiagnosed, they are underreported. Hence, they are highly neglected in Africa, and they are causing a lot of mortality among affected individuals. And there was a roadmap which was published back in 2015 on the diagnosis and management of fungal infection. And this was published by David Denning, Professor David Denning from Manchester University. And this roadmap, it was to take us to the improvement of fungal diagnosis and improvement of management of fungal infection. And through this roadmap, the ambition was at least by 2025, this is next year, we have less than a month to reach next year. This is 2025. At least by 2025, 95% of the population should have access to fungal diagnosis. So we are lab scientists, we are health professionals here in this Zoom call, we are community in this Zoom call, we are working in our laboratory. One thing we should ask ourselves, how have we capacitate our laboratory to be able to diagnose different fungal infections? And then from there, we can answer, have we reached the 95%? Can we accommodate 95% of the population who access our laboratory on the diagnosis of fungal infection? But going to the pharmacy, because in the roadmap, we targeted that at least 95% of the population should have access to antifungal therapy by 2025. Looking at our pharmacies, the community pharmacy, the hospital pharmacies, do we have access to all the antifungal, at least the basic antifungal agents, which are needed so that at least 95% of the population who are diagnosed with fungal infection can get access to antifungal therapy? Is that something that we are capable of in our country, in our regions, and in Africa? These questions answers are no. And we did one of the study in 2022, looking at the roadmap that we had targeted in 2015, and to see where Africa had reached, looking at the laboratory with the protocol for fungal diagnosis. So we looked at different laboratories in different countries. We wanted to target to see how many countries have laboratory with biosafety level 3. Because fungals have to be handled in how many labs? And as you can see in the map, there are very few laboratories. There still have countries which do not have laboratory with the level 3 biosafety level. But even those ones with level 3 biosafety level, we have a number of countries which they don't have protocol to handle fungal diagnosis. So they have the level 3 biosafety laboratory, but this level 3 biosafety laboratory is mainly for handling tuberculosis, and mainly for tuberculosis, not for fungal. And they don't even have a protocol for fungal diagnosis. And this was 2022. So we are still not anywhere near the 95% of the population in Africa to be able to do the fungal diagnosis, have access to fungal diagnosis. And this fungal diagnosis we're talking about, these are the basic fungal diagnosis that we're talking about. So in the same year, 2022, we went ahead and looked at the capacity of our fungal diagnosis in Africa. So this was fungal infection, and we looked at the basic tests for fungal diagnosis. Different types. There's a very wide range of tests that can be conducted in the laboratory. For example, the age-related infections like coccal, we look at the availability of antigen tests and the utilization of antigen tests. And then for pneumocystic pneumonia, we look at the availability and the utility of PCR for diagnosis of pneumocystic. Also for culture, and we look for the availability, for the protocol, availability and utility of fungal culture in different laboratories. Looking at those results of 2022, we realized that when it comes to cryptococcal antigen tests, the crack test, a very common crack test, we do have some countries where crack test is not public available. This includes our brother DRC, this includes our brothers in Sudan, Ethiopia, and so many other countries that we are seeing in the orange. They are available in Tanzania, Kenya, Uganda, in Rwanda. They are available in public health facility, but we have some countries like where they do have the crack test, but utilization of it is only occasionally. And it's mainly in research, mainly when the patient have completely beneficiation, that's when they come to think of crack test. So we still have some countries like Madagascar, like our brother in Burundi, Nigeria, Niger, where they are there, but it's only occasionally when they do crack test. It's not as what is happening in Uganda, Kenya, and Tanzania. Looking at the eye infections, the fungal keratitis, a very common infection for people who are working in cassava plantation, very common for people who are working in banana plantations. So whenever they get eyes crushed by anything when they're working on their garden, they're working on their farm, then the spores they're there and soil. So it's easy to get inoculated with eyes. You should remember that the eyes are immunological area. And so we said let's look at the availability and utility of crime scrapping and direct microscopy for the fungal keratitis. So when we look at the mama, we can realize that the fungal keratitis direct microscopy for fungal culture, they are not available in most of the African countries. There are very few countries in Africa where at least they have those, they have protocol for the diagnosis of fungal keratitis. So it's there in Uganda, it's not there in Tanzania, in Kenya, it's not there in DRC, in Ethiopia, it's not there. So it's only 4 or 5 countries in Africa where they have a protocol for the diagnosis of fungal keratitis. And yet fungal keratitis is very common in Africa because we are the ones working most of the times in agricultural sectors. And working in agricultural sectors, we are prone to get this cramping, and then the fungal spores getting related to the eyes. But both are related to the skin infections, very common to children, very common for immunocompromised individual. We went to for a very simple test like microscopy, skin microscopy, doing the potassium hydroxide preparation. At the laboratory, how to doing potassium hydroxide preparation. It's a very simple test that you can just tap the skin, put it on the slide, put the potassium hydroxide, put it under our objective lens and then under my microscope. There are very few laboratories which can do even that skin scrapping and do the potassium hydroxide preparation for fungal diagnosis. Go ahead, fungal culture, uses the scrapping and do the fungal culture. Very few countries which have the laboratory with protocol for doing those diagnoses. You can see that we have some countries like Somalia, Sudan, Angola, where they don't have no public lab. They don't know about the potassium hydroxide preparation and using it for microscopy for the fungal diagnosis. So we can still see that it's very large part of Africa. We are still underdiagnosing fungal infection, and yet these fungal infections they are there. We went ahead and look at cancer because cancer is emerging in Africa, and we have a large number of cancer patients who have cancer, diagnosed with cancer, undergoing chemotherapy. And we should remember having a cancer itself is a problem. It's compromised the immunity, depends on the type of the cancer, but most important when it comes to fungal infection, we talk of most important because hematological malignancies most of the times end up compromising the neutrophil number and neutrophil functionality. Hence, the patient very high risk of getting fungal infection. So this patient with cancer and patient who are admitted in ICU, they are at high risk of being invasive fungal infection, include invasive candidiasis, the candida in the blood. And also they are at very high risk of getting invasive aspergillosis, from chronic pulmonary aspergillosis to invasive aspergillosis, patient in ICU and patient with cancer at very high risk. So for these ones, we look at the ability of doing blood culture, fungal culture. We know that blood culture, it has very low utility. It's only 50% of the patient that it can capture. But at least if we can start with that one, then we can say if we started looking at the blood candidiasis laboratory with capacity to do the blood candidiasis for diagnosis of fungal infection. I know that we have a lot of labs in Africa who are doing blood culture, but now protocol for doing fungal diagnosis is a different story. Majority of them, they end on bacteria, and then they don't diagnose. And it's sad because sometimes even when the fungal had grown on blood agar, because candida can grow on blood agar. So when candida grow on blood agar, they end calling it gram-positive cocci. They call it bacteria, and then the test is for antibiotic, and they become resistant to everything. So they report it as a gram-positive cocci, which is multi-drug resistance, and yet it is a fungal because they are lacking protocol for diagnosis of the fungal. And looking at that data, availability of the protocol for doing fungal infection was very low, but went ahead also looking at Aspergillus antigen test, availability of these tests for Aspergillus antigen test, we found that majority of the countries, they don't have this Aspergillus antigen test. And the ones which are having, like Tanzania, we had it, but this was for research purpose. It was not for the clinical diagnosis. We are still having it, but we are using it for research purpose, not for clinical diagnosis. Same for the lung infection, fungal lung infection like chronic pulmonary aspergillosis and the rest of the lung infections. The story is the same. Very few countries have protocol, have laboratory that with protocol for diagnosis of the lung fungal infections. And we have some countries like Zambia, Somalia, Libya, they completely do not have their laboratory do not have a protocol for diagnosis of these fungal infection. So the question is, how should we strategize? We are still living in Africa. We are not going to leave Africa tomorrow and we are going to live in Europe. No, we are going to stay in Africa and we love Africa. We want to be a part of Africa as well. So how should we strategize? First, to reduce fungal infection to the immunocompromised individual, because we are in Africa and immunocompromised individuals are there. We have patients with kidney problems, we have patients who are going for organ transplant, we have patients who are admitted in ICU, we have patients undergoing major surgeries, we have patients with cancer. All this population is there. So how should you strategize to reduce the risk of fungal infection in Africa? That's the first thing. After we've reduced the risk, then the few who are going to get the infection, then we have to improve the diagnosis capacity so that we detect them very early and then we manage them early. So we have, these one have been grouped in different categories. First is to increase the awareness in the education to our clinician, to the laboratory scientists, the laboratory technologists. We should be aware fungal infection are killing our relatives, our brothers, our sisters out there. So we should increase the awareness and education. And thanks to the team which organized this webinar, these Zoom meetings, because this is one of the platforms where we increase awareness. We educate our colleagues that, okay, think of fungal infection, think outside the box of bacterial infection. But after increasing the awareness to the clinicians, after increasing awareness to the lab technicians, we should improve the diagnosis. We should make availability of these diagnoses, because the clinicians are going to request for the test, and then the test should be available in the lab so that we detect and we manage the patient accordingly. But coming to the environment and the housing where we are living, we should be able to address the leakage and in the households out from our own houses. We have a lot of molds which are eating the walls. The molds which are happening in the walls, you find the wall has turned to become black, the molds has grown there. These same molds which are grown on the molds, the spores can cause problems to the immunocompromised individual. If you have an immunocompromised individual at home and in the hospital facility, in the health facility, that should strictly being reduced. But we should also optimize the healthcare to combat injuries, because when you go for injury like road traffic accident and you get injury, then we are at risk of getting this fungal spores to the wound and we get infection. But improve the access of water and hygiene. We should improve our hygiene, because the moment you improve the hygiene, the dermatophytes will become a story. You will not have, will significantly reduce the dermatophyte. Will significantly reduce the cutaneous candidiasis when you improve the water, hygiene, and sanitation behaviors. But in healthcare facilities, we should also reduce highly significantly reduce the number of spores, especially to the wards where the immunocompromised individual are. These include the oncology ward, the cancer wards. We should really be careful on the cancer ward, the way we manage, the way we do disinfection and sterilize and the cleaning of the floors in the major surgical wards and in the cancer wards, the oncology wards, but also in ICU, in theaters. We should be able to minimize the number of fungal spores that go in. But for our brothers who are working in high risk work, like the one who are working on a construction, the ones who are working on timbers, they should be protected from the fungal spores. But because remember, the fungal spores, they are found everywhere in the environment, and majority of them, they are found in plants, and plants are materials. So the ones who are working in timber, they are very high. They have a very high risk of inhaling the spores of aspergillus, the spores of a lot of fungus. So our brothers who are working on the timber and constructions settings, they should be protected. They should have the mask. They should be encouraged to do the personal hygiene, to improve their personal hygiene, so that you reduce the risk of fungal infection. But after we've reduced the fungal infections, the small population who are at risk are still at risk of getting infection, or are getting infection, should still be diagnosed in our lab. And the question is, should we start with everything? Where should we start from? That's the big question we should ask ourselves. How should we start in Africa? Yes, we have immunocompromised individuals, and we are going to have them. We are going to stay in Africa. We've already said that we are going to stay in Africa. We're not going to leave from Africa. So this immunocompromised individual will be there anyways. So where should we start? WHO had put up the fungal priority pathogens where we should concentrate at least first, and this is invasive fungal infection. We should first think of invasive fungal infection, and these include cryptococcosis, the cryptococcal lymphoma, which cause cryptococcal meningitis, especially in people living with HIV. We have Candida auris, which causes a lot of outbreaks, especially in ICU and surgical wards and neonatal wards. We have this Candida auris, which causes a lot of outbreak elsewhere in the globe. In Africa, it has not much being reported, but it does not mean that we don't have Candida auris. Candida auris is also there, so we should also at least start with the critical group of the fungal priority pathogens, and these include Aspergillus fumigatus, which causes chronic pulmonary aspergillosis. And why Aspergillus fumigatus? We should remember that majority of countries in sub-Saharan Africa, they are endemic. Sorry, someone is drawing up in the slides, so could you please stop that? So majority of African countries in sub-Saharan Africa, they are endemic for tuberculosis. And when the patient have got tuberculosis, the tuberculosis leave cavities in the lungs, and it's within these cavities where the fungal spores goes and colonize and start causes chronic pulmonary aspergillosis. So CPA is one of the infection that we should also think of starting with. So if we were to start a protocol in your lab, if you are to establish protocol for diagnosis of fungal infection, what I will advise is to start with these fungal in the critical group, the critical group of the fungal pathogen, at least to have a protocol for diagnosing these ones. The chronic pulmonary aspergillosis, because this is the main gateway to invasive aspergillosis. Getting invasive aspergillosis, most of the times, it starts with inhalation of the spores to the lungs. Then whenever they found the cavities which have been left by tuberculosis, then there they are. They colonize, they causes the infection. But also Candida albicans, the one causing invasive blood candidiasis. And why Candida albicans? Because it also seems to gaining a lot of resistance to fluconazole. Fluconazole is the mainstay, is the main drug that we are using in sub-Saharan Africa in management of the fungal infection, majority of the fungal infections. From cryptococcal to Candida infections, we are using fluconazole, but Candida albicans is one of the species that seems to get a resistance to fluconazole. So this is one of the pathogen we should also target. As we think of starting with the priority, with the critical group of the pathogen, we should ask ourselves, what is the status in our country? I will share a bit of my country, Tanzania, and my colleague Benson will share on the status of Uganda. And then from there, we can think of what is the status in Rwanda, what is the status in Congo, what is the status in your country when it comes to fungal infection. In Tanzania, fungal infections are there, and they are causing mortality. So a previous study, which was done by one of my colleagues, Fine, in 2015, reported on the invasive fungal infection, include cryptococcosis, and you could see the rate of the cases, 100,000 people, it was estimated to be 14.6% of the population. This is 66,394 per year of the patients, HIV-infected individual, getting cryptococcal meningitis. Coming to the PCP in Tanzania, back then it was around 9,600 per year, back in 2015, and the cases might be the same or might be different. But looking at oropharyngeal candidiasis among cancer patients who are on chemotherapy, the study that we did in 2022, we did it in 2022 in Ocean Road. It's a national cancer hospital. We found a majority of the oral candidiasis are caused by non-albicans candida species, not albicans candida species. Majority of them is non-albicans candida species, and it was led by Candida krusei. And Candida krusei is of public health importance because majority of them, up to 80% of Candida krusei, they are inborn resistance to fluconazole. We should remember fluconazole is the mainstay antifungal agent that we are using for management of patients with fungal infection. But in Tanzania, majority of the patients with oral candidiasis who are on who are cancer patients on chemotherapy, they were having Candida krusei. Means here we cannot rely on fluconazole. We should think of voriconazole. We should think of caspofungin or any other antifungal agent for this kind of the population. But looking at the urinary candidiasis, is very rare for the population that we studied in Tanzania. We found 5 in every 100 patients with the urinary tract infection, they are having urinary candidiasis. The prevalence is very low, but doesn't mean that we should close our eyes when it comes to urinary candidiasis, because with time, this is going to increase. And of public health importance in this population where we found urinary candidiasis, majority of them, they are also having non-albicans candida species and most Candida glabrata among this population. So you can still see that we are at risk, we are playing at the risk of having infections which cannot be managed by using fluconazole. And yet fluconazole is the mainstay when it comes to fungal infection in Africa. But talking of aflatoxinosis, the aflatoxins in maize, the study that we did in 2023, we published it this year. We went to the local markets where the maize are being sold ready for human consumptions. We found up to 11.1% of the maize sample that we took were contaminated with the aflatoxin. They already have aspergillus flavors on them, and the aspergillus had already produced the toxin, the aflatoxin. And remember, the aflatoxin leads to liver problems, lead to the liver cirrhosis and liver cancer. So it is not something that we should close our eyes. And of them, 3.3% of the sample had concentration above the acceptable standard in East Africa. In East Africa, 10 microgram per kilogram of aflatoxin is acceptable. But the sample that we took, 3.3% had above 10 microgram per kilogram. So you can still see that fungal infection is a problem, all the way from the food that we are using to the patient that we are managing in the hospital. It is not something that we should neglect. Sorry, the slides are not moving, but looking at the antifungal resistance, the study that we did on antifungal resistance, we found, sorry, okay. So the study that we did on antifungal resistance, we found that this is just for Candida albicans.
Professor.
Do you see my slide?
Just share. You can kindly reshare. We have lost your slides.
Okay, sorry.
You can reshare. So
Yes, I'm trying to share it. So on the study that we did on the magnitude of the antifungal resistance among Candida causing different range of infections in Tanzania. And this is only for Candida albicans, because Candida albicans is the one that WHO had set it as a priority fungal pathogen, and it's in critical group for the blood candidiasis. But this was not for blood candidiasis. This was for different range of infection. We had women with high vaginal with the vaginal candidiasis, where we took high vaginal swab, and we found prevalence of fluconazole resistance to be less than 10. It was very high on esophageal candidiasis among patients with esophageal candidiasis, but the rest of the infection, it was very low, below 5%, of which it's a good news, but it should not say that we should stay. We should keep quiet. We should keep on watching. We should keep on observing on the antifungal resistance, and we should keep on maintaining the usage of antifungal resistance. The study that we've done here in Tanzania, we found that antifungal are overprescribed by clinicians without microbiological confirmations of the disease, and they're also being used over the counter. And even fluconazole is used for vaginal candidiasis for women without without doctor's prescription. So we should also watch over this and should keep maintaining this antifungal resistant trend. We should not go above 10, at least 10%, because the number of the antifungal agents that we are having in the market is very narrow for African continent. From this point, let me welcome my friend and my colleague, Dr. Benson, to proceed with the slides. Welcome, Dr. Benson.
Thank you, Martha. I beg that you stop sharing, then I share from this side so that I can control the flow of slides.
Yes.
Thank you.
Yes, thank you.